different stages. पीछे वॉइस किसी का आ रहा है? Please mute. Okay. So testicular tumor. We have to first remember. किसी का voice आ रहा है, please. अभी. Okay. So testicular tumor, we have to remember. Apart from TNM and staging, two more things. One is the serum markers. Some particular things in the history. I won't go into finer details. I will go that much which we have to remember till the exam day. Number one is the serum markers. Serum markers S1, S2, S3. It depends on three things: AFP, beta SAG, and LDH. So S1 is good, S2 is intermediate, S3 has poor prognosis. So we remember the intermediate one. Intermediate AFP levels are 1000 to 10,000. Testicular, BCG is 5,000 to 50,000, and LDH is 1.5 to 10 times the normal. Depending on that, we divide the patients into S1, S2, S3. And then again, in early stages, especially stage 1, we have some low risk and high risk groups. In seminoma, greater than 4 centimeter, we call them as high risk. If there is an invasion to testis, these are also high risk. In the non-germ cell tumors, embryonal component is more than 50%. LVI, PNI, if proliferation is 70%. So before coming to TNM, we have to remember these two things. Now I will shift to TNM very concisely. T1, T2, T3. T3, we remember it is spermatic cord. T2 is when there is LVI inside the kidney, inside the testes, and tumor limited testis T1 less than 3, greater than 3. T4 is scrotum. Then N1 is less than 2 centimeter. I won't go into the pathological. Simple. I want to make it very simple. So N1 is less than 2 centimeter, N2 is 2 to 5, N3 is greater than 5. Metastasis is further divided into two, M1A and 1B. M1A is when there is retroparental, other than retroparental nodes, and there is pulmonary metastasis. And when these two things are not there, it is M1B, means other side metastasis. So then we will divide it into three stages: stage 1, stage 2, stage 3. There is no stage 4. Okay. So stage 1 is what? Stage 1 has two components. Before that, there is 1S. Again, voice आ रहा है. अभी भाई, किसका voice आ रहा है? Okay. So in before stage 1, there is IS, means there is only markers are raised. There is no evidence of tumor. Then we come to stage 1. Stage 1 has been divided into two: 1A and 1B. 1A only tumor limited to kidney. Okay, fine. And whatever there is, if there is LVSI, if there is spermatic cord, if there is a scrotum involvement, no nodes, it is 1B. Fine. Then whenever the nodes come, stage 2 comes into play. So T1, stage 2A is when there is N1 disease, less than 2 centimeter node. No markers raised. Stage 2 is 2 to 5 centimeter node retroperitoneum. Stage 2C is more than 5 centimeter node. Just itna ba kafi hai abhi tak. So stage 1 is limited to kidney. Stage 2 is to retroperitoneal nodes. Stage 3 is metastasis. Stage 3 is further divided into A, B, C. A is when there is first M1A, means it is pulmonary mets, and S0, S1. 3B is when there is S2, means S2 markers, S2 intermediate, and there is N1, N2 nodes, less than 5 centimeter nodes. S3 is less than 5 centimeter node or non-pulmonary mets, and S3. Fine. Staging clear. Shall I proceed to management? Or if you want clear, I can revise it. Or try to make it simple if you want. Shall I move to staging in this management part?
एक बार रिवाइज कर देना, like just an overview.
If I am fast, tell me, I can stop. Okay, I will go slow. So in testes, we have before TNM, we have to remember the markers. Why markers? As you saw, this S2. Sorry, it's S3. I have written S2. It is S3. S3 becomes directly what? It becomes stage 3C. No treatment, only chemo. Okay, fine. So depending on markers with nodes, it can change your staging. That's why we have to remember it. So S1, S2, S3, three things: alpha fetoprotein, beta HCG, and LDH. Remember the middle one. Rest you can go up and down. Then in early stage of testes, we have to remember high risk, low risk. This is also a risk group, but this is just a refinement of the other clinical characteristics. That is seminoma. High risk is greater than 4 centimeter. If there is hereditary testis involvement, it is high risk. In non-seminomatous, it is LVI PNI, proliferation rate, and if embryonal component is more than 50. Okay. Now you will shift your mind to TNM. T1 limited to kidney, T2 limited to kidney, but LVI present.
ये तुम किडनी बोल रहे थे
Sorry मुझे ये
कोई बात नहीं
दिमाग में you understand
वो हाय आया कोई बात
default enter control enter. Okay. So T1 testis is limited to kidney.
Kidney
no
nahi re testis.
LVSI is there. There are 1-2 things minor, but I will just concentrate on bigger picture. T2 is when LVSI is present. T3 is spermatic cord. T4 is scrotum. N1, N2, N3 less than 2, 2 to 5, greater than 5. M1A, M1B. When there is metastasis apart from retroperitoneal node, if M1A is when other nodes other than retroperitoneum is there, it is M1A, or if it is pulmonary mets, it is M1A. Or if there are anywhere metastasis, visceral metastasis other than lung, it is M1B. Fine. When you are done with this, then stage them. Stage 1 is, remember, in this 1 is 1 in the kidney, 2 is node, 3 is metastasis. Okay. Our important is stage 2. Okay, which they ask to remember simply 2A-B-C less than 2, 2 to 5 centimeter, and 3 is greater than 5 centimeter to make things simple. Okay. Can I proceed now?
Yeah.
If anyone can understand, please, because मुझे भी उतना नहीं आता.
ये स्लाइट करेक्शन देना चाहता हूँ.
प्लीज.
ये जो T1, T2 आपने बताया, इसमें ना T1 में और एक है, इन्वेजन ऑफ ट्यूनिका अल्बुजिनिया इस T1 है, इन्वेजन ऑफ ट्यूनिका वजाइनालिस इस T2 है.
T2 मतलब इट्स
T1, T2 में ना और एक चीज है, इन्वेजन. दोनों ट्यूमर लिमिटेड टू टेस्टिस एंड एपिडिडमिस है. But if there is an invasion of tunica albuginea, it is T1. If it is invasion of tunica vaginalis, it is T2. And जो आप ये good intermediate poor बोल रहे हो, S1, S2, S3, this is only for non-seminomatous germ cell tumor, not for seminoma.
Okay.
So seminoma में there is no poor risk factor. Seminoma में only good and intermediate. And it is any S1, S2, S3 in both good and intermediate.
या वो टेबल भूल गया, तीसरा वाला टेबल देखिए जो आप बोल रहे हैं ना, वो भूल गया. वो आप रिवाइज कर लीजिए.
जो आपने फाइंड ये जो आप T1A, T1B less than 3, more than 3, ये कहाँ से लिखा है? ये AJCC TN में तो नहीं.
कहाँ पे?
AJCC for seminoma है, only for seminoma.
Okay, this less than 3 and more than 3.
हाँ. And tunica albuginea ये नया NCCN में AJCC में, I thought that is older one. नया newer one में कुछ नहीं दिया.
दिया है जो albuginea है.
The newer one.
It's the albuginea है.
तो मैंने सुना confined testis में तो LVSI.
No. Albuginea है, sure.
So in short, in T2 there are two things to be considered: whether LVSI is there and whether vaginalis is involved. Correct?
Yeah, and one more thing. ये जो spermatic cord and scrotum है, इधर भी plus or minus LVI है.
LVI.
और spermatic cord plus or minus LVI, scrotum plus or minus LVI.
So
that doesn't matter.
प्लस या माइनस है तो वो T3 ही हो गया ना.
That doesn't change.
It won't change. हाँ, ठीक है.
It won't change. हाँ.
Hey, what were you saying about seminoma high and low risk? Can you
That
say
is
that?
one more table I have not included here. In seminoma,
Okay.
you have only we do not have poor prognostic. That is good and intermediate, if I'm not wrong.
Yeah,
And
correct.
And in non-seminomas, you have good, intermediate, and poor prognosis.
Poor prognosis.
Basically, in seminoma, there is no poor risk factor.
Poor risk factor.
So even if it is metastatic to lungs, anything, it is always intermediate. It is never poor.
Yeah.
No, so this good and intermediate, you're talking about the S1, S2 division, right? About the tumor markers.
नहीं वो एक
What are you talking about?
रिस्क
Sorry.
स्ट्रेटिफिकेशन क्राइटेरिया है उसका नाम
Seminomatous and
इंटरनेशनल
non-seminomatous.
मेटास्टैटिक जीसीपी का रहता है आईजीसीपी। ये इसमें अलग बताया समथिंग डिफरेंट बेस रिस्क फैक्टर, तो वो प्रोग्नोसिस ग्रुप नहीं बता रहा है, वो अर्ली स्टेज वो इंक्लूड करना था। या एक मिनट वेट करो, मैं इसमें या कोई शेयर कर,
मैं करता हूँ।
जो हम बात कर रहे हैं वो मेटास्टैटिक का है, आईजीसीसीजी वाला। हाँ,
या मेरे वाले में मैंने पूछा ही नहीं किसी को कोई डाउट है या कुछ प्रॉब्लम है, मैंने तो सही पढ़ाया है ना।
नहीं आप डाउट है बाद में बताऊंगा।
Non-seminomatous germ cell tumors are all of the following: testes or retroperitoneal primary, no pulmonary, visceral mets. Okay, and these all will be S1 the markers. Okay, fine. In seminomatous there will be any primary site, no pulmonary or visceral mets, normal AFP, any beta SCG or LDH. So then is intermediate. In non-seminomatous variety, it is testes or retroperitoneal primary, no pulmonary visceral mets, any of the following. Then it is this S2. Okay. Seminoma.
तुमने नो बोला है, नॉन बोला है? नो बोला है, नॉन पल्मोनरी?
नो नॉन पल्मोनरी।
ओके, हाँ मतलब उसमें ऑलरेडी गुड एंड इंटरमीडिएट में पल्मोनरी मेट्स है।
ऑलरेडी पल्मोनरी मेट्स है, ठीक है। सो देन इन सेमिनोमेट्स एज वी नो मार्कर्स का कुछ नहीं है, नो नॉन पल्मोनरी विसरल मेट्स है। ओके, नॉर्मल मार्कर्स है, एनी एलडीएच, एनी बीटा एचसीजी। Poor in seminomatous में है।
So in short, we can say that good prognosis is all M1A with an S1 for NSCC2, and M1A with an S2 for intermediate, and M1B for poor. Correct? No.
Correct.
M1B and S3.
Yes, 3.
So
And
M1A S1, M1B S2, M1B S3. That's how the table
plus
goes.
Plus mediastinal. Primary mediastinal भी poor में आता है। Retroperitoneum and gonadal good and poor में आता है अगर site primary वहाँ है, या mediastinal germ cell ऐसा tumor आता है तो that again becomes poor.
Oh, that bit I didn't notice only. ठीक है।
सिंपल बोले तो नॉन जर्म सेल ट्यूमर्स में वो गुड एंड इंटरमीडिएट, वो mediastinal origin नहीं रहना, बस उतना ही प्राइमरी।
So you can make a table basically of NSGCT good, intermediate, poor as good being, so the mediastinal primary we have to understand is poor, that we have to put there. The rest of the sites are all good and intermediate में दोनों में है, doesn't matter, right? So the only thing is M1A S1 in good, M1A S2 in intermediate, M1B S3 in poor along with mediastinal.
Yes.
And seminoma में क्या है अभी?
Seminoma there is no poor prognosis. Okay, there is only good and intermediate.
And no S1 S2
मैट्स देखने हैं बस। पल्मोनरी मैट्स होगा तो इंटरमीडिएट, और नहीं होगा मतलब नॉन पल्मोनरी मैट्स होगा तो इंटरमीडिएट, अदर विल बी गुड।
So again it is nothing but M1A is good, M1B is
हाँ, उसमें easy हो गया, खाली M1A M1B में good और intermediate में खत्म। ठीक है, fine. We'll make a revision of this table. You add it to your notes, man.
Yeah.
Thanks.
Sorry, I didn't
Continue.
included it.
Hey, no problem. Continue. Sir.
So actually, I wanted to make it very short, but this flow table should have been there. Okay, we'll continue.
पर वो metastatical है ना? I am right or wrong?
Which one? Yeah. This one is for the chance of metastasis early. अभी बताऊंगा इसका role. That one I will tell the role of this. Okay.
हाँ, तुम्हारे ये upper right corner वाले चीज क्या है?
Yeah, this is I am telling early stage. Means stage 1 में some वो ESMO वाले they sometimes give chemo on this. Otherwise, जो ये table by भेजा, this is more important for exam purpose. They might ask this. इसमें important यही है कि seminoma में there is no pore. In NSGC there are 3, as we said. Then non-seminomatous उसमें markers का ज़्यादा रोल है, उसमें नहीं है. तो बाकी हम इसको फिर से रिवाइज करेंगे एंड में. ओके.
Yeah, continue.
I will come to the stage management now. So as I said, what is stage 1? Stage 1 is limited to kidney. Fine. I will
testis.
Sorry. Kindly bear with me, bhai.
भाई किडनी करके आएगा.
अरे भाई ये
किडनी पढ़ा ना इसीलिए वो टार्चर कर रहा है उसको.
None of you are Malayali.
डर लग गई.
There is an
करियो.
ये यूरोलॉजी भाई बहुत डरती तो करते नहीं, ऊपर से समझ नहीं आ रहा करना क्या है. That's why I thought I will discuss it so that ये दिमाग में इसको because when you don't do for a long time, when you don't say these names, it's almost you are not doing. You are not.
That is so true. Things don't come to your mouth. I have a very big thing to say. 2 cases till now.
No comedy.
My staff here, and nothing comes to your mouth. Words will be lost.
That's
you're
what.
Only reading. No, you're not talking to.
ए भैया बात करने का टाइम नहीं है, पढ़ाई करो.
Get lost.
So ready. So how the tumor is limited to kidney. We divide the management in seminomatous, non-seminomatous. Seminomatous. In seminomatous stage 1, the preferred modality is surveillance. Follow. You can give other modalities, but recommendation is surveillance is better. Okay. Now comes the non-seminomatous germ cell tumors. We divide it into high risk and low risk. Okay. So in low risk, in non-seminomatous, this germ cell tumors, the preferred is surveillance. Okay. But if it is high risk, fine. So अभी तुम बोल रहे थे ना, what is high risk, low risk? That comes here. Fine. If I am not wrong, क्योंकि ये here the chance of lymph node metastasis are more.
तो ये जो हमने रिस्क स्ट्रैटिफिकेशन किया, वो पहले वाला यही नहीं बता रहा है.
वो ये नहीं बता रहा. मैंने चेक किया, तभी मैंने इसको रखा था. वो मैं सोचा to avoid confusion this time, because in this there are chances of micromets are in these cases in early stage 1. If it is semin non NSGST, you have found embryonal, there is LVI, PNI, proliferated 70, then you have to prefer BEP regimen. Okay, alternative surveillance. See, we are not practicing. Maybe I'm wrong, but just confirm me later on. But as far as I have checked, this high risk, low risk after NSG you have to divide, and low risk preferred is surveillance. Alternative, you can give BEP 1 cycle. But if high risk are there in early, for example, embryonal, LVI, PNI, proliferation rate is 70, you have to give BEP 1 cycle. If there is contraindication to BEP, you have to do RP-LND in stage 1, limited to testes, non-seminomatous germ cell tumor. So, if the question asks someone in stage 1, when will you do RP-LND? Tumor is limited to kidney. Sir, we will say, sir, if it is seminomatous or non-seminomatous. If it is seminomatous, it is not a preferred modality. Even in non-small cell, non-germ cell tumor, non-seminomatous, it is only indicated when it is BEP is contraindicated. Stage 1 is clear?
Yes.
Anyone wants to add anything?
Yeah. Stage 1 में there are, if the embryonic is there, Other risk factor are basically if there is no maturation, no exact tumor, and size is less than 1 centimeter. So preferably in that cases we opt for the surveillance. If there is size is more than 1 centimeter with the risk factor, you should proceed with the lymph node dissection RP-LND.
Actually, what I said there, NCCN is telling one, ESMO is telling one. There is a lot of confusion. But हमको basic थोड़ा रखना है यार.
Yes.
ये किधर से है?
I think testis में we should go for EUA ना, not for NCCN or ESMO.
ये EUA का भी थोड़ा है. मैं इधर-उधर से मतलब जो मुझे एंड में क्रैक्स समझ आया मैं
EUA का है.
मैं जो भी contraindicated then RP-LND किसने बताया?
I am telling it is from 3-4. I am not sure which one, but only thing is it is not wrong. Okay, whatever it is, I have taken it from somewhere. It is not my.
अभी I think जो Campbell है, Campbell is from European ना. Campbell का जो guidelines आता है वो सब.
उनका EUA गाइडलाइन होता है, वही EUA या AUA होता है उनका. यूरोलॉजी का अलग से गाइडलाइन आता है.
Yes, yes.
So stage 1 में anyone wants to?
So stage 1 में seminomatous tumor में अगर size is more than 4 centimeter or testis involvement, then we give the single dose of carboplatin.
Yeah, I told that is preferred surveillance, but you can give other treatment preferred.
Yes.
I have told that's what this risk is there.
नहीं वो दिखाई नहीं दे रहा था मुझे. हाँ इधर है मिला.
ये risk, okay?
Yes.
Fine. That these are risks for micrometastasis. If it is in the seminomatous.
Can I add something here?
Please.
ये जो non-seminomatous में है ना, like why actually nowadays nobody is doing this RP-LND is there was one landmark trial which happened actually in the 2008 में. बस et al का ना एक लैंडमार्क ट्रायल हुआ था जो एक्चुअली ये RP-LND को सप्रेस कर दिया. उन्होंने बोला कि 2-year RFS PEP 1 cycle वर्सेस RP-LND का उन्होंने एक ट्रायल किया था. RCT था, एक प्रॉपर लैंडमार्क ट्रायल था जहां RFS with BEP 1 cycle was 99%, whereas with surgery जो था वो कम था, 90 around था. So that is the reason why RP-LND has taken back seat. This reason why PEP 1 cycle is preferred over RP-LND in stage 1 non-seminomatous germ cell.
ट्रायल का नाम
ये ओलिवर वाला है ना.
ट्रायल का नाम क्या है?
अल्बर्ट का था ये, RCT था ये 2008 में. ये लैंडमार्क ट्रायल है एक्चुअली. एंड ये जो सेमिनोमा में है ना, इट इज नॉट जस्ट ऑफ कोर्स प्रेफरेंस जो सर्विलेंस रिस्क फैक्टर तो बताया आपने जो प्रॉपर्ली, जो ट्यूमर साइज मोर देन 4 सेंटीमीटर या टेस्टिस इन्वॉल्वमेंट. तो इफ पेशेंट इज हैविंग दोस, it is though it is surveillance is preferred, but Indian population में ना ये surveillance many of the people are not compliant. strict surveillance होता है. तो उन्होंने ये बोला कि irrespective of risk factors, though surveillance is preferred, since in Indian scenario like no people are compliant with this, they always give single agent carboplatin. Single agent carboplatin एक cycle देते हैं, which is as equivalent to RT. फिर और एक ट्रायल हुआ 1 cycle का सिंगल एजेंट कार्बोप्लेटिन वर्सेस 2 cycle of कार्बोप्लेटिन. सो 2 cycle of कार्बोप्लेटिन रिड्यूस्ड 6% से लेके 3% को और फर्दर रिड्यूस हुआ. उन्होंने बोला कि 1 cycle of कार्बोप्लेटिन सिंगल एजेंट कार्बोप्लेटिन इज आल्सो सफिशिएंट फॉर द पेशेंट. सो इंडियन सिनेरियो में दिस सेमिनोमा में प्रिफर्ड सर्विलेंस तो है, ऑल गाइडलाइंस इवन ईवे गाइडलाइंस सारे गाइडलाइंस में है, बट स्टिल अगर ये दो रिस्क फैक्टर्स आते हैं तो वी प्रिफर लाइक एटलीस्ट आवर इंस्टीट्यूशन प्रिफर सिंगल एजेंट कार्बोप्लेटिन.
ओके. ये आरबी वर्क करते हो कोई क्या?
नहीं सेमिनोमा में, अरे सेमिनोमा इज हाईली
नहीं मैं बोल रहा हूं किनको किसी को बता, यू पीपल हैव सीन और डन RP-LND?
या आई हैव सीन. ओके. Though it is very less, very like very strict and very less, but I have seen
3 RP-LND.
Great. Okay, shall I proceed now?
डॉक्टर राकेश ने तो आई थिंक किया भी है.
Oh, so what is the consensus now? Seminoma as बाई का नाम भूल गया मैं.
ब्रह्मानंद.
हाँ. So preferred surveillance, but in Indian
preferred
scenario,
surveillance है ना, वो complaint नहीं रखते हैं बोल के at least one single agent carboplatin देते हैं.
Okay, so Indian scenario
guidelines में भी है, ये में भी है ये guideline.
Yeah, मैं
इसमें ही डॉग लेग आरटी इसमें ही देते हैं ना.
या इसी में
वो आगे वो भी है. There is RT role also. There is, I am telling, I have written the mota. I have not written the finer details क्योंकि ये आगे जाके complex हो रहा है. Okay, you will see when we will go more, it will become more complex. So I have जो जरूरी याद है मैंने वो include किया है. Because seminoma में first stage में RT का भी रोल है, कीमो का भी रोल है, but preferred is if you say surveillance, you are pass. Because if your preferred is surveillance, that is a okay answer. But if you want to be more, then you can write as said carboplatin one cycle, or RT is also having a role. Fine. Shall I go for और क्या बोला था इसने भाई ने? ये RPLND is because of that trial.
Landmark trial, it has taken back seat.
True.
वो trial share कर देना भाई एक क्लास.
तो स्टेज अभी स्टेज 2 पे ए पे नहीं आता हूँ. स्टेज 2B3 का कंफ्यूजन है. आधे 2B उसमें ले जा रहे हैं, आधे इसमें. तो ये एस्मो से लिया है.
स्टेज 1S में
1S में वो नहीं लिखा है भाई, बोल गया.
बता दो. 1S should be treated like 3 तेरा मार्कर्स का.
या
स्टेज 1S का एक्चुअल में जो ट्रीटमेंट मोडालिटी है वो बहुत कंट्रोवर्सी है, बट स्टिल मेजॉरिटी ऑफ द प्लेसेस स्टेज 1S इज नथिंग बट ट्यूमर मार्कर्स बड़ा है, रेस्ट ऑल इज नॉर्मल. तो इसका मतलब वो मानते हैं कि देयर इज सम काइंड ऑफ माइक्रोमेट्स समवेयर इन द बॉडी, सो दे गिव हियर 3 साइकिल्स ऑफ बीईपी फॉलोड बाय सर्विलेंस recommended regime. ये है 1S का.
Thank you. So यहाँ पे first because 2 is more controversial than now, so I kept it later. Stage 2B and 3 from ESMO guidelines. 2B को ज़्यादा तोड़ने की कोशिश करें तो complicated हो जाएगा. But to make it simple, 2B and 3, if it is seminomatous, we have to give 3 to 4 cycles of BEP. Non-seminomatous, we have to see good, intermediate, or poor, depending upon the markers. Okay? Clear? If it is good, S1, means markers are low, we have to give BEP. Okay? Or if you can give in this patient, if markers are not raised, it is 2A, 2B, you can do RPLND also. Okay? If it is S2, intermediate marks, you have to give 4 cycles, not 3, 4 cycles of BEP and or VIP. If it is poor, S3, you have to give BEP, VIP 4 cycle with dose intensification. And then you follow up. So, stage 1 is clear. Stage 2B and 3 is clear. There is no stage 4. 1S also, already we discussed also. So what is remaining? The most controversial and what they ask. That is 2A, 2B. Rather, only 2A they ask mostly. So 2A in Davita they have divided into low volume, high volume. I think by low volume we mean less than 2, if I'm not wrong. They have divided high volume. If I'm not, they have not mentioned this. They have not mentioned high volume, what is high volume, but I think low volume means less than 2. So seminomatous tumor and non-seminomatous tumor. How to manage stage 2A? So full concentration, because 3 times they ask question on 2A. Why they ask? They ask the controversies only. So 2A, now it is seminomatous. Seminomatous is what? It is radiosensitive, chemosensitive tumor. Okay, and non-seminomatous is what? Where markers come into play. Okay, so 2A, 2B. In 2A, we see 2A means there is a node in the retroperitoneum that is less than 2 centimeter. Okay, you have done orchidectomy. There is a node in the scan. What to do now? You know it is seminomatous. You prefer RT. Okay, what RT? You will get 30 grays to para-aortic and to the same iliac nodes. That is called dog-leg regimen, whatever regimen Madam was telling. Or alternate, but that is not preferred. You have to give 3 cycles of BEP. If bleomycin is contraindicated, 4 cycles of EP. So patient came to us, we did an archidectomy. There is seminoma and there is less than 2 centimeter node. We have preferred modality RT or chemo. Then another patient, we had an archidectomy, it came seminomatous tumor. There is 2 to 5 centimeter node. What to do? Preferred is not RT here. Here preferred is chemo because chance of micromets above the nodes will be more. So if you give RT only, you won't be able to treat original systemic mets. So give directly, prefer here 3 BEP for 4 EP. Or if chemo is contraindicated, give RT with a boost to the node. Clear? Right?
Yep.
So if a seminoma, you had done an archidectomy, there is a node more than 5 centimeter. What you do? What to do?
Chemo.
Hello? Hello?
Chemo.
Yeah, it will go to stage 3B. 3. Sorry. Okay, stage 2C. It will go here. So till now, seminoma over. Okay. Now we will go to stage 2A non-seminomatous tumor. So stage 2A non-seminomatous tumor, we know the role of markers come now. In seminomatous, there is no marker anywhere. There is only size criteria of node. So you have done an archidectomy. There is a node less than 2 centimeter and it came as non-germ cell, yolk sac, something else. So what to do? You will send for the marker. You will check the marker. If marker is raised, means it is a systemic disease already. So don't touch the patient. Send for the chemotherapy. Okay. Even if node is less than 2 centimeter. If the node is less than 2 centimeter and markers are not raised, what to do? We have here 2 options. You can prefer neurosparing RPLND, follow the patient, or you tell the patient wait, come after 6 weeks. Okay, check again the markers. If markers regress, you follow. If markers are stable, less than 2 centimeter node is there, you do neurosparing RPLND. If the marker progressed, or if the disease progressed, more than 2 centimeter more than 2 centimeter, you again send the markers. If markers are still not negative, we are concerned about negative markers here. We never do RPLND if the markers are raised. That is the crux of the whole story. But why we are keeping him wait in alternate option? So as to decrease the morbidity in less than 2 centimeter node. Because in one subset, it has regressed. So in non-seminomatous tumor, if we find marker normal, you will directly go for RPLND, or you give him an option that wait, come after some time. Repeat marker. If marker regressed, very good, lucky enough fellow. If it is stable, disease is stable, marker is negative, then you do RPLND. If this disease got progressed, marker is still negative, right? You do RPLND. If marker got raised when you called him next time, so better to send him to chemo. It is as good as the first option, marker raised NSGST. Okay? Clear?
Yep.
Yes.
Fine. So now the question they have, I will tell the question what has came in the exam. There is now how to follow the patient in the residual disease. That I will wait. Okay, let me go to the question. So the question they have asked is, how will you manage a 4 centimeter lymph node mass in the retroperitoneum with a raised marker in a case of NSGST? Okay. So where it will fit?
2B.
So it will fit here. Okay. So what to do in this case?
Marker left. Non-seminomatous or seminomatous?
We have to check the marker. We have to check the marker. No. We have to check the marker here. Node is more than 2 centimeter. Wait. Don't get bluffed here. Okay.
Already raised marker बोला ना वो?
हाँ मतलब raised marker है ना?
Non-seminomatous है या seminomatous?
Non-seminomatous बन जाएगा.
I will tell you. So 4 centimeter node in the retroperitoneum NSGST with marker, with raised marker. So it will go into the
second line chemo.
It will go in this intermediate or it will go into the S3. Which one it will go? S2 or S3?
मार्कर कितना रेज है?
कितना रेज है?
Not told. Raised
marker. तो we can just say that we'll give PEP 4 cycles, ना?
दोनों
डोज का नहीं लिखने का ना.
We have to read both. I think because उसने कुछ दिया नहीं है.
मगर सेमिनोमा में मार्कर्स नहीं बढ़ते ना. We have to deal right in terms of non-seminomatous बोल देना.
Non-seminomatous.
NSGST बोला मैंने. दोनों लिखना है. Okay. So we have to write both. Fine. दूसरा क्वेश्चन क्या पूछे हैं? Discuss the management of stage 3. Stage 3 हो गया ये वाला बॉक्स. कहाँ गया?
तो अभी तो खुला था.
ये वाला है ना? नहीं किधर गया? ये वाला. स्टेज 3 में. हाँ स्टेज 3 में अगेन वही सेम ही पूछा है. मतलब ऑलमोस्ट स्टेज 3 में भी ज्यादा कीमो का ही रोल है. ओके. और मार्कर इनमें करना है. और क्या क्वेश्चन पूछा है? इंडिकेशन ऑफ कीमोथेरेपिक रेजिमेन इन टेस्टिकुलर कैंसर. मतलब जहां जहां ये बीईपी आ रहा है वो डिस्क्राइब करना है. ओके. अगेन वो क्वेश्चन पूछा है 4 सेंटीमीटर नोड इन रेट्रोपेरिटोनियम. 2 बार आया है सेम क्वेश्चन. इस पे क्वेश्चन आया है 2 बार. ओके. तो एक तो ये लिखना है, उसके बाद इसको ऐड करना है. ऐड क्या करना है? फॉलो अप. ओके. अभी तक क्लियर है?
But role of RPLND
हाँ बोल. ये आता हूँ ना इस पे जैसे. आता हूँ. ठीक है. तो अभी तक हमने क्या किया? हमने प्राइमरी मोडालिटी दिया सबको. स्टेज 1 में either you have given chemo or in seminomatous you have given 2 you have given RT somewhere. कहाँ गया? कहीं तो है. You have given RT here, you have given RPLND. So now comes the role of how will you follow a residual disease. तो पहले मैं सेमिनोमा का बोलता हूँ. So patient came to follow up. There is residual tumor. So how will you manage? And it is the second part of the question what has been asked. Okay. So if the disease is progressive, mass is increasing, markers are going up in a seminoma, you start second line. Okay. Three scenarios. When everything is going out of hands, he came back, you send for second line. In seminoma, you have 3 centimeter risk criteria. In non-seminomatous, you have 1 centimeter. इतना याद रखना. ठीक है?
Yes.
Okay. So in seminoma, 3 scenarios. First I told, if the markers are going up, mass is increased too much, nothing done, send for this chemo, second line. Now other 2 scenarios. If there is a residual mass but it is less than 3 and normal marker. So seminomatous है, less than 3 centimeter mass है, retroperitoneum में, normal marker है, you observe. अगर रेसिडुअल ट्यूमर है ग्रेटर देन 3 सेंटीमीटर है, मार्कर नॉर्मल है, you will tell him to come after 6 weeks and you do PET. Okay. What will happen? You again put into 3 categories. If PET is normal, negative, मतलब कुछ इन्फेक्शन कुछ तो है, कुछ खास नहीं है, सर्वेलेंस में डाल दो. अगर इंटरमीडिएट आया, मतलब प्लस माइनस पॉजिटिव नेगेटिव आया पेट पे, you again put him scanning after 6 weeks. अगर इस टाइम आपको पेट में पॉजिटिव आता है अपटेक, you put for RPLND. You call it post chemo RPLND. Okay, fine. Then जो आपने ट्यूमर निकाला उसका बायोप्सी क्या है, उस पे आपका फॉलो अप रहता है. Now after some time you check the biopsy. बायोप्सी में कुछ मैलिग्नेंसी नहीं है तो बस घर भेजो, फॉलो अप करो. अगर वायबल या ये सेमिनोमा, you add 2 cycles of EP. अगर वायबल सेमिनोमा में और पॉजिटिव स्कैनिंग में फिर से कुछ आया है, ठीक है, you give second line. ओके, यहाँ पे सेकंड लाइन इधर था ऊपर. तो जो रेसिडुअल मास है ग्रेटर देन 3 सेंटीमीटर नॉर्मल मार्कर थे, वो एज गुड एज पहला वाला. सो सेकंड लाइन कीमो के बाद फिर से बुलाओगे, फिर से यही टेबल ऊपर वाला. कीमो की सेकंड लाइन के बाद फिर से जैसे फर्स्ट साइकिल के बाद या सेकंड लाइन के बाद फिर से ये पुराना वाला नेगेटिव है, को सेकंड लाइन के बाद फिर से प्रोग्रेसिव डिजीज हुआ. थर्ड लाइन दे दो, रेसिडुअल डिजीज लेस देन 3 सेंटीमीटर नॉर्मल मार्कर सर्वेलेंस पे डाल दो. ग्रेटर देन 3 सेंटीमीटर नोट है भैया, सेमिनोमा है, नॉर्मल मार्कर है, फिर से पेट पे भेजो. फिर से वही कहानी शुरू हो, ये वाली. ठीक है, पेट के बाद नेगेटिव आया तो सर्वेलेंस डाल दो, इंटरमीडिएट आया तो फिर से बेचारे को पेट पे लगा दो, पॉजिटिव आया तो उड़ा दो. ठीक है. अगर वायबल सेमिनोमा आया, ओके, और इमेजिंग पे फिर से पॉजिटिव है तो थर्ड लाइन देना है. वायबल सेमिनोमा इमेजिंग में नहीं है कुछ तो एड कीमोथेरेपी, कुछ नहीं आया तो फॉलो अप. ओके. अगर इसके बाद भी थर्ड लाइन के बाद भी आपको ट्यूमर आता है, फिर से थर्ड उसको बोलेंगे डेस्परेट RPLND. ओके. अगर आपको सेकंड लाइन कीमो के बाद ट्यूमर आता है, यू विल टेल इट साल्वेज RPLND. अगर आपको पेट के बाद फर्स्ट कीमो के बाद RPLND करते हो, इट इज कॉल्ड पोस्ट कीमो RPLND. ओके, चलो ये खत्म महाभारत. अभी दूसरा. सो first you have given this patient as first line chemo. First line chemo, he came back with a residual disease greater than 3 centimeter. Markers are normal. 3 centimeter mass after first chemo in seminoma, you won't leave. You have to do something, even if marker are normal. If marker are raised, nothing, no tension, you give chemo. But here normal markers are normal and mass is 3 centimeter more. You subject to PET scan. If PET scan shows positive, you have to do something. Uptake is there in that 3 centimeter more than mass. It is called post chemo RPLND. You subjected him to second line chemo. After second line chemo again, it showed greater than 3 centimeter, again another mass. Okay. Now you do again RPLND here in the after second line chemo. That is called salvage RPLND. If after third chemo the mass again you became frustrated, you do desperation, you do desperate RPLND. Okay. चेक कर लेना, मतलब बोल रहा हूँ, मत यही है, लेकिन समझे यार।
पोस्ट में सॉल्वेज को एक ही समझते थे पहले, अभी
आई थिंक डिफरेंट है, डिफरेंट।
डेस्परेट वाले में सीरम मार्कर्स भी रेज रहते हैं,
पोस्टकीमो डिफरेंट है, सैलवेज डिफरेंट है। सैलवेज सेकंड लाइन के बाद आता है, थर्ड लाइन के बाद डेस्परेट है, श्योर।
नहीं, डेस्परेट में ना सीरम मार्कर्स भी रेज्ड रहते हैं और नोड भी रेज्ड रहता है, फिर भी हम कर रहे हैं, तो डेस्परेट रहता है।
डेस्परेट में व्हाट यू सेड इज राइट, मार्कर्स रहते हैं, सब रहता है, बट इफ इट इज स्टिल ऑपरेबल वी विल ऑपरेट आउट ऑफ डेस्परेशन। ऑपरेबल है, केमिकल मेडिकल मैनेजमेंट में कर सकते हो, सर्जिकल भी कर सकते हो। ये सेकंड लाइन के बाद जब इफ यू वांट टू ऑपरेट यू कॉल दैट एज डेस्परेट आरपीएल। सेकंड लाइन के बाद
थर्ड साइकिल।
नो ऐसा नहीं, अभी का डिस्कशन में ये लोग दूसरा बोल रहा था।
फर्स्ट लाइन के लिए अगर नॉर्मल हो गया मार्कर तो इट विल बी पॉजिटिव, ओके। सेकंड लाइन दिया उसके बाद भी नॉर्मल नहीं हुआ तो अपन थर्ड लाइन देके फिर
So it is exactly what Ashfaq said first only, no?
that we want to clear the post city और सैलवेज में क्या ये साइकिल का डिफरेंस, मतलब लाइन का डिफरेंस है, फर्स्ट लाइन सेकंड लाइन కొడుతూ ఏం రాని నెట్ కనపడుతుందా నీకు?
चले
किसका स्पीकर ऑन है भाई?
So finally it's a mark.
No, seminomatous, PET scan और 3 सेंटीमीटर याद रखना है। Non-seminomatous we have to remember 1 centimeter margin, 1 centimeter criteria। अगेन non-seminomatous आया तो मार्कर आना ही आना है। अगेन S1 S2 S3 में डिवाइड करेंगे as we did above। कहाँ गया भाई? Here स्टेज 2A 2B में S1 S2 S3 में non-seminomatous डिवाइड किए तो वापस आया हमारे पास, तो फिर से इसको S1 S2 S3 में डिवाइड करेंगे, S1 S2 S3 में डिवाइड करेंगे। अगर मार्कर नॉर्मल है, गुड प्रोग्नोसिस है, बीईपी दे सकते हैं, या तो नॉर्मल है तो आरपीएलएनडी कर सकते हो, ओके। इंटरमीडिएट है तो बीईपी 4 साइकिल, वीआईपी 4 साइकिल। ये क्या लिख दिया मैंने भाई? अच्छा ये यहाँ पे, सॉरी फॉलोअप यहाँ पे तो रिपीट हो रहा था। सो अगर ये मार्कर वापस आया तो हमको पहले देखना है एज आई साइज। इफ नॉन सेमिनोमेटस जर्म सेल ट्यूमर में साइज मोर देन 1 सेंटीमीटर है, मार्कर देखना है, ठीक है। अगर मार्कर नॉर्मल है या मार्कर रेज्ड है, आई विल अगेन रिपीट, नॉन सेमिनोमेटस है तो मार्कर इंपॉर्टेंट है। 3 सेंटीमीटर सेमिनोमा में था, 1 सेंटीमीटर नॉन सेमिनोमेटस में है। अगर मोर देन 1 सेंटीमीटर है, नॉर्मल है, आरपीएलएनडी करो, ओके, नो कंफ्यूजन, ओके। अगर मार्कर रेज्ड है मतलब सिस्टमिक डिजीज है, मोर देन 1 सेंटीमीटर है तो डिवाइड करो पेशेंट को। नॉर्मल है तो आरपीएलएनडी के बाद हमको पैथोलॉजी देखना है। एम्ब्रियोनल आया, योग सेक आया, कोरियोकार्सिनोमा आया, EYC, तो 2 साइकिल ईपी और टीआईपी दे दो। टेरेटोमा आया तो कुछ नहीं करना है, ठीक है।
इसको कंसोलिडेशन कीमो बोलते हैं, जो यहाँ पे हम कीमो दे रहे हैं ना एचपी के बाद, कंसोलिडेशन कीमो बोलते हैं।
किसके बाद?
ये 2 साइकिल्स ऑफ हिस्टोपैथ आने के बाद, अदर देन टेरेटोमा है तो 2 साइकिल्स ऑफ ईपी दे रहे हैं ना, उसको कंसोलिडेशन कीमोथेरेपी बोलते हैं। टेरेटोमा एनीवेयर यू फॉलो, अदर हिस्टोलॉजी यू हैव टू गिव कीमो, कंसोलिडेशन कीमो।
सो अभी दूसरा बच्चा जो हमको रुलाएगा वो है मोर देन 1 सेंटीमीटर एंड मार्कर इज रेज्ड। इसको फॉलो अप करेंगे, बोलेंगे भैया डाउट है, थोड़ी देर के बाद आ जाओ, लाइक एज दिस वन, विच वन, जिसका नॉर्मल मार्कर था 3 सेंटीमीटर था, Similarly 1 centimeter नॉर्मल किधर गया भाई 1 सेंटीमीटर इंक्रीज मार्कर ठीक है उल्टा है थोड़ा
That time is fixed.
हाँ तो कुछ टाइम का कुछ पता मिला नहीं
Fine.
सो मार्कर रेज्ड है तो अगर ये ऑन फॉलो अप एलिवेटेड एंड राइजिंग है सेकंड लाइन देना है ओके एलिवेटेड बट स्टेबल है क्लोज सर्वेलेंस करना है द मार्कर केम टू नॉर्मल ओके माइल्डली एलिवेटेड है तो सर्जरी करना है आरपीएलएनडी करना है एंड देन चेक द हिस्टोपैथोलॉजी ओके so
you call it as post chemotherapy RPLND either?
Yeah, same whenever you do any RPLND after first cycle you call it post chemo RPLND whether seminoma or non seminoma. So if I have to tell you when will you do RPLND in non seminomatous after post chemo, when will you do RPLND in seminomatous post chemo? उसका बोलो सेमिनोमा में when will you do RPLND in post chemo?
When greater than 3 centimeters से PET activity positive है.
Correct.
More than 3.
PET activity होना चाहिए.
More than 3. In non seminomatous
greater than 1 centimeter है normal होना है मार्कर.
नॉर्मल नहीं यही कंफ्यूजन है मार्कर रेज है
नॉर्मल है तो कीमो देना
नहीं
अगर नॉर्मल है तो
हाँ सर्जरी करते हैं
ग्रेटर देन 1 सेंटीमीटर बोलो
any mass greater than 1 centimeter you have to operate in RPLND.
Yeah correct fine अगर नॉर्मल मार्कर है तो करना ही करना है
हाँ
okay if marker are raised we have to think fine
markers raised है तो 3 options है ना like markers are elevated 3 categories elevated and persistently rising elevated but stable वहीं पे elevated but later on they are coming to normal decrease हो रहा है तो on follow up we can post them for surgery post chemotherapy RPLND जो stable है ना you have to follow whether increasing or decreasing है तो surgery के तरफ भेजो increasing है तो persistently rising category में डालो persistently rising category on follow up ज्यादा ही आ रहा हो तो then you start second line chemotherapy
so second line chemo के बाद
so one thing Ashfaq in this you can't just write close surveillance that is not right either means after the close surveillance there has to be 2 arrows they either get pushed to the left or to the right
that should be
that sounds wrong no like it sounds
stable
like
वाला
हो गया उसका follow up है अभी the middle place
स्टेबल वाला दोनों तरफ एरो जाएगा नॉर्मल हुआ तो सर्जरी जाएगा हाँ नॉर्मल होता सर्जरी पड़ा तो सेकंड लाइन कीमो
गुड सो अभी सेकंड लाइन के बाद क्या हुआ सेकंड लाइन
फिर रीअसेसमेंट सीटी एंड ऑन
या अगर इसको कंप्लीट रिस्पांस आया सो पहले ये वाला कौन सा कैटेगरी है मार्कर रेज्ड है एंड राइजिंग है इसको हमने कीमो दिया था इसको कंप्लीट रिस्पांस आया तो इसको सर्विलेंस करेंगे या तो सैल्वेज आरपीएलएनडी करेंगे ओके फाइन नेगेटिव मार्कर्स कंप्लीट रिस्पांस आफ्टर सेकंड कीमो we can do surveillance or salvage RPLND. Confusion now clear?
I think in non-seminomatous there is no concept of surveillance. Once it has responded, you have to do it.
You check.
पता नहीं. Less than 1 centimeter है तो follow करते या नहीं पता. अगर ये greater than 1 centimeter है ना?
Depends on pre-chemo size. If pre-chemo is more than 3 centimeters, post-chemo you have to do.
Okay.
Non-seminomatous. One.
ओके फिर उसके बाद है अगर सेकंड कीमो के बाद इसको पार्शियल रिस्पांस आया रेसिडुअल मास आया ओके हियर दैट अदर देयर वाज नो मास एट ऑल ओके सो आई थिंक बेटर टू वेट सर्विलेंस देन सैल्वेज आरपीएलएनडी बिकॉज कंप्लीट रिस्पांस है मार्कर भी कुछ नहीं है सो सेकंड सिनेरियो में पार्शियल रिस्पांस है मतलब ट्यूमर है मार्कर नॉर्मल है तो आरपीएलएनडी करना है किसी भी सिनेरियो में सो उसके बाद आप देखोगे अगर टेराटोमा है या EYC है, उसी के हिसाब से आगे चलोगे। थर्ड सिनेरियो है पार्शियल रिस्पॉन्स है। ओके, मार्कर अगेन रेज्ड है। मार्कर रेज्ड है तो कुछ थोड़ा संभल के चलोगे। मास भी है, एलिवेटेड राइजिंग है जैसे ऊपर है तो थर्ड लाइन स्टार्ट कर दोगे। एलिवेटेड स्टेबल है, फॉलो अप करोगे। एलिवेटेड एंड नॉर्मलाइजिंग है तो RPLND।
तो सेम थिंग हियर, वो फॉलो अप उधर जाने वाले हैं।
हां, सेम रिपीट होगा।
ये रिपीट हो रहा है सर। So this is all about. So one reason I didn't include that table because that didn't help me in the management anywhere if I'm not wrong.
वो मेटास्टैटिक का है?
नहीं वो वाला बोल रहा हूँ जो ना मैं वो फोटो डाला था, क्योंकि मुझे समझ नहीं आया वो कहाँ पे अप्लाई होता है। वो
मेटास्टैटिक का है वो।
मेटास्टैटिक का है। हाँ।
सो दूसरा मैं पूछना
मेटास्टैटिक में ट्रीटमेंट क्या है?
मेटास्टैटिक बोलो ना।
Stage 3 itself is metastasis in testis.
Yeah. So then this is this thing whatever algorithm to follow. तो उसमें in this good to intermediate poor में कुछ difference आता है?
ये है ना, ये लेकिन मार्कर बेस्ड है, but this is marker based.
That's what I'm asking.
वो भी मार्कर पे ही था ना, ऑलमोस्ट। मतलब मीडिएशनल प्राइमरी छोड़ दो एक।
Okay, ठीक है। So this is where that comes. Your table comes in this picture.
Number 2 डाउट मेरा था, what is they are telling high volume low volume, वो क्या है? वो कहीं पे लिखा है क्या?
बता रहा था ना भाई अभी, less than 2 more than।
अच्छा, मतलब किसी जगह मिला नहीं मुझे वैसे।
क्या है लेस देन 2 नोड से? क्या है वो लेस देन 2 साइड से? कैसा है वो? साइड से, नोड से?
आई थिंक लेस देन 2 सेंटीमीटर लो वॉल्यूम
नोड का ही होगा वो तो।
N1 is low volume बोलना है फिर। अगर N1 के बाद लेस देन 2 सेंटीमीटर मल्टीपल नोड से, इफ यू सी दैट stage 2 is divided into clinical stage 2 pathological stage 2 है ना। clinical stage is before surgery, CT के हिसाब से देख के ट्रीटमेंट स्टार्ट करते हैं। So थोड़े लोग क्या करते हैं, सर्जरी कर देते हैं stage 2 में when retroperitoneal nodes are there. On final histopathology you decide it as pathological N1, N2, N3. there फिर चेंज होता है। N1 is less than 2 single node or multiple nodes, none of them greater than 2 centimeters. चेंज होता है ना।
उसके बाद फॉलो अप कैसे करेंगे? हिस्ट्री एंड एग्जामिनेशन, चेस्ट एक्सरे एंड CT MRI एब्डोमेन पेल्विस 1 2 3 4 5 4 month पहले साल 6 annually 6 chest x-ray and MRI as clinically indicated. This was the management part of this.
एक्चुअली मोहन ने ना एक एक्चुअली इम्पोर्टेंट पॉइंट बताया है अभी, जो पैथोलॉजिकल स्टेजिंग जो बताया ना। क्लिनिकली आप बोल रहे हो N1, N2, N3 is less than 2 to 5 centimeter, more than 5 centimeter. But there is something called as pathological N1, N2, N3 also.
Yeah, more than 5 nodes.
Less than 5 nodes, but less than 2 centimeter is N1. More than 5 nodes, 2 to 5 centimeter with extranodal extension is N2.
उसका रोल किसमें आ गया?
बट वो हमें
PLND के बाद डिसाइड होता है क्या देना है। अगर फॉर एग्जांपल कीमो देना है नहीं देना है, कंसोलिडेशन कीमो देना है नहीं देना है, डिपेंड्स ऑन दैट पोस्ट RPLND।
हिस्टोपैथ देख के देते हैं ना।
हां
कितना साइकिल देना है वो डिसाइड होता होगा, एग्रेसिव है कि नहीं है ऐसा।
हां साइकिल तो 2 ही है जो कंसोलिडेशन में जो देते हैं ना पोस्ट RPLND। PN0 में तो सर्विलेंस है, PN1 में भी सर्विलेंस है, PN2 में 2 साइकिल्स है, N3 में 3 साइकिल।
ओके। और ये भी रहता है क्या कि नॉन स्माइनोमेटस में 2 साइकिल दे दिया फिर भी स्टेबल है तो RPLND कर देंगे स्टेबल में?
आफ्टर लाइक व्हिच स्टेज?
स्टेबल का उधर आएगा नहीं ना। लेस देन 3 सेंटीमीटर, ग्रेटर देन 3 सेंटीमीटर, वही है कांसेप्ट ऑफ लेस देन 3 फॉलो अप करो।
नॉन सेमाइनोमेटस।
अच्छा, नॉन सेमाइनोमेटस।
यार लास्ट जो बता रहा था ना,
कौन सा राकेश दोबारा बोलो?
तो रेसिडुअल मास का बता रहा है वो जो लास्ट में।
हां रेसिडुअल का ही बोल रहा हूं।
ओके
रेसिडुअल मास ग्रेटर देन 1 सेंटीमीटर।
ग्रेटर देन 1 है और अपन ने 2 लाइन कीमो का दे दिया फिर भी स्टेबल रह रहा है सुपर मार्कर, तो RPLND कर देंगे, ऐसा कुछ है क्या? अवनीत से
पोस्ट को डेस्परेट आरपीएलएनडी कुछ बोलते हैं ना, पोस्ट
उसी हाँ करेक्ट, उसको डेस्परेशन
रेज्ड नहीं है ना, नॉर्मल है, स्टेबल
नॉर्मल। हाँ, डेस्परेट आरपीएलएनडी करते हैं उसको।
स्टेबल और रेज्ड दोनों को डेस्परेट बोलेंगे।
दैट इज सैल्वेज।
नहीं, उसको सैल्वेज बोलेंगे। अगर नॉर्मल मार्कर से तो उसको सैल्वेज आरपीएलएनडी बोलेंगे।
इट इज नीदर नॉर्मल नॉट इंक्रीजिंग, लाइक स्टेबल है, जितना फर्स्ट लाइन के बाद था उतना ही सेकंड लाइन के बाद है, ना कम हुआ ना ज्यादा हुआ। सो ऐसे में क्या करेंगे, मेरे को कहीं पढ़ा हुआ याद आ रहा है, एग्जैक्ट मेरे को नहीं पता, मे बी आरपीएलएनडी कर देते हैं सेकंड लाइन के बाद भी अगर स्टेबल है तो।
सो नॉन
फॉलो भी करेंगे वो दोनों में से
करेक्ट है। नॉन सेमिनोमैटिस में ना अगर वो स्टेबल भी रहा तो the next option is surgery. That means it indirectly indicates the pathology is teratomatous rather than the other, which is not responding to chemo. So we will do RPLND.
उसको ही डेस्परेट बोलते हैं ना आनंद?
नहीं डेस्परेट इंक्रीजिंग ट्यूमर मार्कर।
हाँ, इंक्रीजिंग ट्यूमर मार्कर को हम डेस्परेशन बोलते हैं।
जो तेरा ये टेबल का लास्ट वाला है ना, फ्लो चार्ट लास्ट, इसमें जो
हाँ
इधर में
आवाज नहीं आ रही तेरी।
जो ये आरपीएलएनडी के बगल में फॉलोअप डाला है ना तूने स्टेबल में, उसमें हम लाइक डिस्कस कर रहे हैं कि
वो फॉलोअप नहीं है, वही मैं बोल रहा था, उसमें 2 लाइन आएगा दोनों तरफ, लेफ्ट एंड राइट। द पॉइंट इज यू फॉलो अप द ट्यूमर मार्कर टू सी वेदर इट इज गोइंग टू बी द सेम और गो राइजिंग। इफ इट्स राइजिंग, कीमो, इफ इट इज द सेम, सर्जरी। Either go for surgery or chemo, whatever happens.
इसमें कहीं पे भी रोल ऑफ बायोप्सी नहीं है क्या, जो रेट्रोपेरिटोनियल लिम्फ नोड एनलार्ज्ड है? So is it only the node or it is a necrosed tissue left? Where is the role of biopsy here?
बायोप्सी मुझे कहीं मिला नहीं,
बोला नहीं कहीं पे भी।
So the thing is, post chemo, one of the times the nodal tissue is left behind. So there is some concept of biopsy here, whether the tissue is actually teratomatous, which will require surgery or not, or it's just only a necrosed tissue. If there is only necrosed tissue, you do observation.
But one thing is there, how will you target a particular difficult target? If there it can be
so
mixed
more than
also,
1 centimeter जो है, you can target.
I'm telling it can be having a mixed component also.
Yeah, you will not know histographical miss.
जो कहाँ नेक्रोसिस रहता है, कहाँ ट्यूमर सेल्स रहता है, उस नोडल मास में it is difficult to.
That is exactly why RPLND is being done.
So there is no role of biopsy.
I didn't get biopsy.
Guidelines में तो mention नहीं है.
This is the early relapse which is occur within a 2 year. So ideally you should do the biopsy to see whether the potential for the teratoma at the site. Yeah, within a 2 year, what the European guidelines suggest.
So that is only the indication, right?
Yeah.
Apart from that, there are no other indication. Okay.
Before starting any treatment, you should biopsy.
You should do. Yeah. Okay.
Yeah.
Correct.
Okay, before RPLND, we have to do biopsy also.
No. So recurrence आया तो within 2 years से सब.
After completion of treatment and during follow up, जो लास्ट में 4 दिखाता है ना, 6 months.
Okay, not in any of these charts. Means these are all during the treatment of the patient, right? We are talking about after some DFI, something.
Post completion treatment.
Post completion.
Okay, basically you are talking about relapse.
Relapse.
Yeah, early relapse.
उसका आरपीएलएनडी का भी नाम है ना कुछ, जो 24 months के बाद आता है?
Redo RPLND.
Redo is failure of the first RPLND. वो नहीं है, redo नहीं है वो, उसका नाम अलग है। नहीं
redo mostly failure ही हुआ ना, relapse
नहीं
group.
Okay.
44.
And even there is a role of stem cell transplant also in relapse, early relapse. Though not recommended, but वो second category भी है, but early relapse में तो STIP या VIP regimen है. अगर second option is there is autologous stem cell transplant का भी रोल है.
Okay.
Hey, one more doubt. Wherever you wrote VIP, it was all optional with DEP, no?
Yeah. And what is V in VIP?
I think it is Winblast.
Wincristin,
No.
Winblast.
No.
क्या है?
Minoralman.
Mineral है ना?
नहीं.
फिर क्या है भाई?
ये तो एकदम bouncer हो गया.
Actually, in olden days, VIP में ना, they used to sell a brand name. तो website बोल के brand name से बेचते थे. V is actually etoposide.
And IP?
IP is ifosfamide and P is cisplatin. So V is not Winblastin or Vinorelbine.
So it is EIP in short. Like how we are saying EP, it is EIP.
but they call it regimen famously VIP हुआ क्योंकि वो brand इतना famous हुआ उस टाइम पे कि website
हमको तो खाली meaning to say you're giving three drugs of two drugs. Two of the drugs are the same in both of the regimen. Ifosfamide is getting added in one.
So V is epirubicin, huh?
Etoposide.
EP में भी etoposide है ना?
That is VIP में. हाँ, EP में भी etoposide ही है. और एक regimen आता है VEIP.
हाँ.
VEIP में वो अलग है, वो that is Winblastin. क्योंकि the brand name is Velban. Velban brand name VE is Velban ना, so तो वो brand name से वो famous हुआ regimen. So that is Winblastin there.
So the two regimen that today we were learning were etoposide with platin versus etoposide with ifosfamide with platin, correct, no?
Yes. And one more is VEIP. That is.
उसमें we know क्या है?
Winblastin, ifosfamide, cisplatin.
Winblastin, okay, ifosfamide, ठीक है. चल मैं पढ़ाती हूँ.
Yeah.
So I just like whatever notes I could make a little, what you say, clearer because the rest of the notes that I have is like very badly written. So अभी के लिए मैं वो जो notes clear बनाई हूँ वो मैं present करती हूँ. The rest of it I'll present, but notes में बना के share करती हूँ, ठीक है? Share screen. Is it visible?
Yes. Yeah.
So this I'll share, but it's not complete. जो है वो discuss करते हैं अभी के लिए. So yeah, this is just some points I've written. It's not a very whatever proper notes of soft tissue, but points. Okay, whatever is useful wherever. I studied this for a case presentation, not for theory. But anyway, it'll be useful. So if anyone asks you what are the points that favor a soft tissue sarcoma, why call it a soft tissue sarcoma, why would you suspect it? There are 5 points that should mention. A deep-seated tumor, size more than 5 centimeters, progressively increasing in size, pain being associated with it, and obviously a recurrent tumor. So these 5 things are important to remember in terms of any soft tissue mass that presents to you, that it is suspicious for a sarcoma. Now, which are the sarcomas known to have lymph nodal involvement? In general, sarcomas have 3 to 5% involvement of lymph nodes, but in these, the mnemonic is SCARE. It's allowed 20 to 40% chance of having lymph node involvement. So it's synovial, clear cell, angio, rhabdomyo, and epithelioid. Okay? And yeah, so just follow through. It's not going to be something continuous. Random points hoga. So obviously now someone can ask you what are the lymph nodes which are clinically suspicious. Anyone has any points to add to this, please do. So some of it that I just took out together is obviously the shape being a little rounded spherical, size being usually more than 1 centimeter, hence palpable, consistency being firm to hard, and obviously if it is fixed to any surrounding structure. Anything anyone wants to add to this? Clinically suspicious lymph node, कोई पूछा तो कैसे पता चलेगा?
हाँ, यही है सब.
ठीक है. So now coming to a little more core topic, soft tissue sarcoma में क्या risk factors है बोलेंगे तो couple of things are there. One is genetic. So genetic में we have to know Li-Fraumeni syndrome. So what is it? It is a germline TP53 gene mutation होता है. So individuals में क्या क्या cancers हो सकते हैं? Soft tissue उसमें most commonly what I've written on the left with the arrow is rhabdomyo, what is it? Undifferentiated pleomorphic and fibrosarcoma. And the others are osteosarcoma, breast, leukemia, brain tumors. And a very key feature is this adrenocortical carcinoma. And all this generally tends to occur below the age of 45. So there is this criteria called Chomfred criteria. So hence this age is cut off that they have given. Any of this This is the LFS spectrum, the Leaf-Romney spectrum. These all tumors. If it comes before the age of 46, that is before the age of 45 or equivalent, or in any first or second degree family member, any of these tumors come. Then multiple tumors in the same person, 2 of which belong to this spectrum, and the first one was before the age of 46. Adrenocortical carcinoma specifically in any person, you have to go ahead and test them for Leaf-Romney syndrome, or even in tumor in choroid plexus. These two are sort of, core characteristic for Leaf-Romney. Some other genetic factors are FAP, familial adenomatous polyposis, which is a germline APC gene mutation. Gardner's उसका variant, उसमें extraclonic manifestations में especially desmoids देख सकते हैं. Hereditary retinoblastoma also, germline RB1 gene mutation, उसमें भी risk for soft tissue sarcoma is more. उसमें leiomyosarcoma ज़्यादा बहुत देखते हैं. And the age is usually, age is usually 30 or more after the diagnosis of retinoblastoma. Usually retinoblastoma kids में diagnose होगा ना. So around the age of 30, we'll be seeing them with the soft tissue tumor. Even in case of non-irradiation, that is usually they say, RT ka, after you irradiate, there is a higher risk. We're coming to that. So even in a non-irradiated retinoblastoma patient, you can expect to have a soft tissue sarcoma after about 30 years of the diagnosis. Another genetic condition is neurofibromatosis, both 1 and 2, दोनों में mutations में increased chance है. Either malignant peripheral nerve sheath tumor is the most commonly seen. Then the other risk factors, as I said previously, irradiated patients. So especially it is seen after 10 years after the radiation. It is also dose dependent. So higher the dose, higher the chance, like especially more than 40 gray, a younger age of exposure. And one example is when RT is given for lymphoma, people used to see breast cancers in them and angiosarcomas in them. Chronic lymphedema, as we all know, that Stewart-Trevor syndrome, lymphangiosarcoma dekhte hain usme. Chronic irritation due to chemicals can cause liver sarcoma. Viruses like HIV are also associated, especially the human herpes virus 8, which is a causative for Kaposi sarcoma. So now a person presents to you with a soft tissue tumor. Obviously, you should all know that you have to image first before a biopsy, so that all the changes in the imaging can be prevented due to the edema, hematoma, all that. X-ray obviously baseline में बोलने ही पड़ते हैं because of the bone involvement to rule out and to see how much it is. Otherwise, ultrasound generally a preliminary investigation. क्या-क्या देखेंगे? Plane of swelling, the distance or involvement of the neurovascular structures, the axillary lymph nodes can be determined. Obviously, depending on the site, it can be inguinal, etc. But I just mentioned it like that. Again, the same thing. Ultrasound में क्या-क्या features could be suspicious is spherical, loss of fatty hilum, the cortical thickening. USG obviously also helps in guided biopsy. Why do you have to go for a guided biopsy? Again, the whole point we were just discussing, the heterogeneous nature of this tumor. You have to target the area which is solid, not the cystic area, not the hemorrhage, not the necrosis. So, isme wo 4-needle biopsy is what is generally preferred. So when I presented the case, one of the sirs just asked me, what is the gun color, what is the gun size and all. So that's what I've mentioned on top of this page. 14 gauge is green, 16 gauge is purple. That's what we generally use. So 14 to 16 gauge बोल सकते हैं. MRI is preferred investigation locally. Contrast MRI, in fact, if someone asks you a quote for it, it is through NCCN itself. They've mentioned it like that over CT. Location wise, in retroperitoneum and abdomen, generally CT is preferred over MRI. Why so? Talking about generally in soft tissue, because of the better soft tissue delineation, a 3D image is better in MRI. And there are some features which I have not mentioned in this, but I have to go read again, which can help in differentiating benign malignant, even in differentiating low grade from high grade. MRI features that will be added later. Okay, now role of PET-CT was asked. Role of PET-CT is actually for soft tissue everywhere in NCCN. They don't really mention it upfront. They only say that if you're going to give a systemic therapy like chemo, you can use it for comparison of the response, just like any other site. So response to chemo, they have also found through studies that the SUV max correlates with the grade and prognosis of the tumor. So higher the SUV max, actually you can suspect it to be a higher grade tumor and also having a worse prognosis. उसमें एक ये भी like point भी लिखा है कि after giving chemo, the change, if it is more or equal to 40%, the SUV max का change, then the chance of recurrence and death after a surgery, a good wide excision, R0 excision and radiotherapy, that is a good treatment, is lesser as compared to those who have a lesser response in terms of less than 40% change in SUV max. So that percentage में लिखा है कि recurrence free survival 5 year में 80% रहेंगे ये लोग को as compared to the others who will only have 40% 5-year recurrence-free survival. Angiogram, obviously, if you're suspicious of any neurovascular, abutment and involvement and encasement and all that, you can get a CT angio depending on the site. Chest. So in the metastatic workup, when you talk about it, actually, if it is a low grade, less than 5 centimeters superficial tumor, this thing, what I've written here, this side, you can mention just a chest X-ray, but otherwise HRCT thorax is preferred. When do you do other workup? Like, do you have to do abdomen? Do you have to do spine? Do you have to do brain? Aisa puche to in these specific histologies, it might be required. So abdominopelvic CT might be required in angiosarcoma, leiomyo, myxoid or round cell lipo, epithelioid, and those without a definite, like there are so many things where we are not able to really come to a good conclusion about the histology before the surgery, right? So that time it's better to go ahead and get a workup in terms of abdominopelvic CT. MRI spine is only for the liposarcoma, myxoid, round cell. And brain, this recently we had a case here with brain mets, young guy, alveolar soft part you should always remember, and angiosarcoma. Brain mets is seen most commonly in these two histologies. Yeah, this is a very important thing. Biopsy, kaun karna hai, kaise karna hai, some points. It should be done by the person who is going to plan the final surgery. It should be along the future resection axis with minimal dissection and complete hemostasis, because obviously the planes should not get, further destroyed or whatever. Like, you should have good hemostasis so that does not contribute to any mets. So if a soft tissue mass presents, these are the diagnoses that can be there. I mean, even from a clinical perspective, a simple division, I've just written it here because it was coming up in this is mostly from NCCN guidelines, by the way, those notes, okay. So desmoid ho sakte hain, simple sa. Otherwise benign tumors ka DD mein lipoma, lymphangioma, all the fat hai, muscle hai, all that you have to give the DD. Lipoma, lymphangioma, leiomyoma, neuroma, nerves hai. Malignant mein, it can be obviously carcinoma, melanoma or lymphoma. That should also come to our mind as a differentiate. Any of this can present with a soft tissue mass, especially in the extremities. Now, what all details do we require from a biopsy? All this usual diagnosis, site, size, depth. Isme grade important hai, necrosis important hai, obviously margins important hai, and the mitotic rate. And we also want to know there are some, we'll come back to that. Anyway, there are some ancillary techniques. So there is a lot of discussion on like coming to a conclusion of which kind of histology it is, the difficulty in coming to it just through the morphology, that is just the histopath. So ancillary techniques, aisa kuch questions aa sakte hain. What are the techniques used? There is obviously cytogenetics. Every cancer you can obviously mention all of this. Conventional cytogenetics, IHC, electron microscopy, and molecular genetics. In terms of molecular genetics, in soft tissue sarcoma, even though all this details are mentioned, as far as I read and discussed with the pathologist here, there's not much role as of now where we're able to target much, but we'll come to that later. In this, we just need to generally just mention these points if at all asked. Okay? When do we go for incision biopsy? What is the role? So all this was about core needle biopsy, very minimally, invasive or whatever, right? It's just the gun. Now, when do we have to plan an incision?
Mekha, I have a doubt. So for making the diagnosis of any kind of sarcoma, all we do is a biopsy and IHC, no other techniques as of now, right?
No. That nothing else is standard as of now. But then there is a lot of talk, molecular, aisa, usme,
cytogenetics.
Yeah.
Is it done now?
It is done, but is it common? No. Can it be done? Yes.
And
so
yes,
the whole, all these CMEs or conferences, if you attend, they'll keep discussing molecular a lot. But then are we really doing it in our clinical practice? No.
So they also ask with this core, how many cores you will take? And
length and course, correct. It is about 6 and minimum 2 centimeter, 1 to 2 centimeters in length, and from multiple directions within the tumor. Obviously, guidance is preferred so that you can target the solid areas.
And you will send them all in formalin or some in saline and like that?
Wo this IHC ke liye na.
Yeah. So they ask this, and then MRI mein they ask what should be the protocol of taking MRI, like from where to where?
From where to where? Okay, the joint above and below.
Yeah.
Extremity.
And उसमें वो भी है ना, T2 weighted, diffusion weighted, वो भी करना है ना?
Yeah, करना है, but उसका कुछ भी details मेरे को नहीं पता.
हमको भी नहीं पता, just asking.
No, that's why
ये क्या protocol है?
I wanted to add it.
ये biopsy का क्या
arrow is for
protocol
that.
है? Like how many we have to send in formalin, how many in saline and all?
वो
ये क्या है?
इलेक्ट्रॉन, लाइक वो बोला ना, ये सब बड़ी बड़ी चीज इलेक्ट्रॉन माइक्रोस्कोपी एंड ऑल, उसके लिए एक क्लास में देखा था, किसका था याद नहीं आ रहा मुझे, तो they were asking like that.
The thing is, ideally, initially when you're taking a biopsy, you should be prepared that the person will require all sorts of tests. Means you're not already prepared that they will have any ancillary technique. But what if they require it? So you are supposed to like split it and send. Some in formalin, some in saline. Saline is the other thing, that's all. Because once you put formalin, it changes the, what do you say?
Yeah.
All this structure.
Liver mets risk किसमें ज़्यादा रहता है? Liver mets.
Liver mets, sir.
All where
liver और bone मेरे को पूछा, मैं आंसर अभी तक नहीं किया.
You told already. You did abdominal CT ना? Why you did for liver mets only?
हाँ यही है, angioleukomyosis, epithelial myxoid. Bone भी पूछा था मेरे को, spine के अलावा bone, spine बताई थी मैं, but other bone, soft tissue tumor going to bone.
मतलब एग्जैक्ट याद नहीं आ रहा, मे बी होता होगा कुछ.
हाँ, so
इविंग्स में होता है क्या?
करेक्ट मैन.
नहीं, इविंग नहीं है, वो कुछ और है, कोई एक पर्टिकुलर है, शायद alveolar soft part है जो जाता है बोन में, शायद alveolar है.
Alveolar soft part हो सकता है, because the guy who presented to us is somewhere extremity and now he has, I think, palate and brain. So maybe it is one young kid. ठीक है. So we were in incision biopsy. So it is usually not preferred, but then if co-biopsy is not there, a co-biopsy fails, especially after 2 attempts. So maximum 2 attempts of co-biopsy, that is you repeat 2 attempts. After that, you go ahead and plan an incision biopsy if you're not able to get the diagnosis. They say that don't go ahead with a local anesthesia because it will open up planes that you probably don't want to open up. So go ahead with a general or a spinal. And the incision, obviously, just like the smaller one, it has to be in line with the final planned incision where you're going to resect, and also longitudinal to the limb. Don't raise any flaps. Minimal dissection with complete hemostasis. Drain generally don't place. If at all you have to, you place it proximal to your incision so that you don't increase the, length that is being lost, say in amputation or etc. And along the line of the incision. Proximally placed near and along the line of the incision. Now this is that part of the histological grading, French Federation of Cancer Center Sarcoma Group, FNCLCC, histologic grading. There are 3 parameters: differentiation, mitotic count and necrosis. So usme the important point to remember is necrosis starts from 0. Okay? The points are 0, 1, 2 for necrosis, while for mitotic count and differentiation it is 1, 2, 3. Yeah, I mean, as you look at it only, you'll have to by heart it sort of, but you can remember it as 1 is resembling normal, which is easy to remember. 1 will be lower thing, right? 2 is you know what the histology is, and 3 is the things which are undifferentiated sort of, embryonal, undifferentiated, and all these higher things that we hear, synovial sarcoma, the soft tissue osteo, the soft tissue Ewing's, all that comes under 3. And LMS, leiomyosarcoma, generally is if it is low grade, it is generally good, so that you can put with 1. I mean, this is difficult to remember, otherwise you'll have to sort of use your own cues to remember. But normal, something that you know is 2, that is histology is certain, and 3 is 1, it goes towards embryonal or undifferentiated. In terms of mitotic count, 0 to 9, 10 to 19, more than or equal to 20 per 10 high power field. That and all, some examiners tend to ask what it is not. So details you should know. Per 10 high power field, it is in 40x magnification that you're looking at it, and you have to look at the most mitotically active area when you're counting the mitosis. Necrosis is, as I said, important point here to note is 0, 1, 2 pe hota hai wo. 0 is no necrosis. So it is easy to remember that other 2 can't be no, right? So necrosis no ho sakta hai, to uske liye 0 hai. 1 is less than 50%, 2 is more than or equal to 50% of tumor necrosis. So iska grading ke hisab se bhi grade division hai, that I have not mentioned here, that if you want we can take up NCCN and see. See this, as I said, the scores. Yeah, here, this left side you're seeing down, okay? So total differentiation, mitotic count, necrosis score of 2 or 3 will be under G1, and 4 or 5 is G2, 6, 7, 8 is 3. Sorry, my bad. So my sir, I'm just telling you all the points, whatever came across in the discussion. He told that in the TNM also you're supposed to mention this even in a clinical examination. You're supposed to say GX, it seems. Okay? Like, we obviously say TNM, right? At the end, if you think that it's a case of soft tissue sarcoma bole to. So he mentioned that you have to mention it as GX, grade not assessed, cannot be assessed. Whatever. So this is of clear significance in the TNM. So I think extremities, if you want, we can just have a look once. That is just for the staging. 1A, it's easy. It's pretty easy, but you all have to look at it on your own and figure out your ways of remembering. But how I remembered, I'll tell you. Obviously, grade 1 only grade 1 comes in stage 1. That's it. The important thing is only grade 1 comes in stage 1, and stage 4 is any grade, obviously. So grade 2 and grade 3 are within 2 and 3. So grade 1 is only stage 1. Usme easy it is. 1A is T1 N0. Everything else is in 1B. All the N0s known. So most important thing, first thing is nodes and metastasis both are stage 4. In soft tissue sarcoma, both N plus and M plus is stage 4. As you can see here, any T, N1 and N0, any T, any N, M1 is stage 4. So once there's a nodal metastasis and once there is a distant metastasis, it becomes stage 4. The rest only. So we are only talking about N0. So only T you have to divide and grade wise. So grade में easy हो गया. Grade 1 is under stage 1. Grade 2, grade 3 में खाली एक ही चीज है इसमें. I'm not remembering each of the stage 3s either. So go through this on your own. I mean, it is difficult to sort of give you cues.
Apart from soft tissue sarcoma, any other cancer where node positive becomes stage 4 directly?
To list out, na? There are many. I'm not able to get it.
I think one more I remember is
HCC, yeah.
HCC.
And retroperitoneum. Retroperitoneum soft tissue sarcoma N1 is actually stage 3B, not stage 4. There is only one difference.
Okay, yeah. Retroperitoneum it is different.
Oh, I had only read extremity here. Where retroperitoneum is?
Sarcoma mein, that is not stage 4.
Okay, so amongst the
rest of the sarcoma is stage 4. Only the retroperitoneum is stage 3B.
Okay, so only retroperitoneum is stage 3B mein. Or which are the other ones you guys said lymph node mets becomes stage 4?
Stage HCC. Hepatocellular carcinoma. At least we know this much. There might be other also.
Yeah, true. So should I continue without the notes? The rest of it I don't have a clear notes. It's all scribbled. So
yeah, continue.
Yeah. So then now we'll go on to. So now that we have staged it, now we have investigated it. Now we'll discuss a bit on the types. Okay, so the WHO classification is what they want us to tell, but it is very difficult to sort of reproduce. So what I would say is just have an overview of it, just have an idea what are the headings and what are the things which are important to you to remember in between in each of the headings. So for ease of understanding, I just remember only a few. So so it's very easy to remember soft tissue tumors in general because it's everything that you can imagine from skin downwards, right? So there is fat, there is nerve, there is muscle, there are vessels. So there are vascular things and perivascular things, and obviously something related to the bone also can have tumors like chondroschious and all that. So these are the main headings. If you go through this once, you guys will have an idea. But obviously, no one can reproduce this for sure. But we have to have an idea is what all the bosses are saying. So yeah, we got to go through it. Then there are some questions asked like which are the most common and all, which are not very relevant anymore. You guys, if you find any, because I don't have any evidence for any of it. Like I couldn't find anything where I am able to say for sure that this is correct. So I think now the consensus is that what is that called? Pleomorphic, right? It's the most common. Anyone knows anything about this? I just didn't read too much on that. Most common kya hai soft tissue sarcoma aisa puche to? Because some say liposarcoma, some say that pleomorphic. I'm not sure. So that's out. Now in any soft tissue tumor, I'm talking only about extremities. Please be aware of that. There are other sites also where soft tissue tumors we have to know more. But I read only about extremities at the moment. If we can offer surgery, that is Obviously, if it is not stage 4, everything other than stage 4, if operable, surgery gives us the best results. But is it alone? That's also something debatable. So first we have to understand two concepts in the surgery associated with soft tissue tumors. One is Enneking, one is Kawaguchi. So what is Enneking's concept? The four terms: intralesional, marginal, wide, radical. Okay? So what is intralesional? Obviously, as the name suggests, it is going through the lesion. We are going to leave behind. It is more easier to sort of think of what are you leaving behind. You will leave behind tumor in intralesional. In marginal, you will leave behind pseudocapsule. In wide, you can leave behind some skip lesions. So the whole concept with Enneking was that there are, because sarcoma is something that follows the tissue planes, it does not really, it respects the tissue plane, so to say. It does not really invade it or infiltrate, it more of expands. So that's why there was this concept that skip lesions in the same compartment can occur in soft tissue sarcoma. So what that means, what is a compartment in terms of extremity, especially muscles, that is the limbs, it is that muscle group, means each place में anterior posterior ऐसा compartments है ना, वो पूरा muscles from origin to insertion, that is what we mean in that compartment. So in that entire place, anywhere skip lesions can be there, and that can be left behind in wide excision was the concept by Enneking. So intralesional mein you are leaving behind tumor, in marginal you are leaving behind pseudocapsule, in wide excision you are leaving behind these skip lesions, while in radical or compartment excision you don't leave, you have least likelihood of leaving behind these things, is what Enneking's concept was of division of how to go about a soft tissue tumor excision. So now what they found is after doing this surgery, so these percentages again are my bosses, that is Vijay Kumar sir's percentages. I have not found any quote for it. I don't know from where he's saying it, but his thing is the recurrence rate said to be after an intralesional excision is 100%, because obviously you're leaving behind tumor. Marginal, where you are leaving behind capsule, pseudocapsule, is 90%, and with wide excision it is 50%, and with compartment or radical excision it is only 15%. So now you'll say, why are we all doing wide excision then? The point is, so even though compartment excision would give you the best surgical results, the morbidity obviously is high. You're leaving, like you're taking out an entire compartment, means functionally that limb will be very poor. You'll have to have a lot of support for the patient to really recover. So hence it was found that wide excision with radiotherapy, with an adjuvant radiotherapy, has the least recurrence rate with the least morbidity. So when you have two parameters being taken together, both the recurrence rate and the morbidity for the patient, it came to a conclusion that wide excision plus RT is almost equivalent to compartment excision. This is the whole idea of how to go about surgery in terms of Enneking's concept of surgical excisions. Now, there was a term I said pseudocapsule, I have to define it. So someone asks you what is pseudocapsule, it is because of the expansile growth of a sarcoma, soft tissue tumor, because it respects the tissue planes, it expands and it pushes the normal tissue outward. So two zones come about. One is the compressive zone and one is the reactive zone. So compressive zone is, you have the tumor, just outside of it is compression happening. So the normal tissue being compressed due to the expansile growth of the sarcoma, that is compressive zone, along with reactive zone. Just outside of this compressive zone, the body obviously, like how any other foreign body, sort of, it reacts. So it reacts by inflammatory, mediators, it reacts by fibrosis, all that will be there around this compressive zone, which is called reactive zone. So pseudocapsule is compressive zone with reactive zone combination. So this is what you cut through when you do a marginal excision. That is why even marginal excision में 90% almost local recurrence आने का chance है. Okay, now what else is there here? Also another disadvantage or something of a radical excision is that obviously functionally it is bad, morbidity is high. Also the area, if at all you have to give post-operative radiotherapy, would be very, very large, and it would include the whole bone, the entire bone, right? Because origin to insertion means it's usually from one end of the bone to the other bone. This is another disadvantage you should know of radical or compartment excision. Now came the concept of Kawaguchi.
Your skin sharing is not seen actually. The only that.
No, actually, मेरे पास कुछ है नहीं.
Oh, okay.
So the rest of it, this is just me verbatim telling. Yeah.
Okay.
I didn't have. I've not made the rest of the notes in a very. It's very what do you say? Scribbly. So I'll make it. I'll what do you say? Share that with it. The rest of it only I've written what I showed today. So Kawaguchi concept is that barriers are existing between these the tumor and the normal tissues, or so to speak, the barriers are already there in the body normally also. So what are these barriers? It is thick and thin. So thick barriers are about the 3 centimeter margin. In terms of a surgeon's perspective, we are talking about margins, right? So thick barriers give us about 3 centimeters and thin gives us about 2 centimeters. In very easy terms, or sort of to remember, thick barriers you can see with your eyes. They look white and tendinous. Thin are the ones you can't see. So thin examples, if someone asks you, it is like muscle fascia, it is like epineurium, vascular sheath, and also an important thing is periosteum in adult. In adults, the periosteum is a thin barrier. In infants, it is a thick barrier. Other thick barriers are sacral fascia, joint capsule, the iliotibial tract in the leg. All these are white and tendinous structures which you can see with your eyes, and they give you a 3 centimeter margin. Capsule of a joint is 5 centimeters. Yeah. Joint capsule cartilage gives you 5 centimeter margin. So in case you're cutting through a joint and you're taking the capsule along with it, you get a 5 centimeter margin in itself. So this is Kawaguchi's concept. Okay. Now, right. So although you say that, there are some situations where you can avoid RT. Now, if someone asks you when, the 3 things that I had mentioned earlier, which I had told, I think for what I told you, somewhere I told this today. Okay, anyways, is 5 centimeter size, the location of the tumor being deep or superficial seated, and the grade. These 3 things actually help you to sort of differentiate a risky tumor, high risk tumor versus a low risk tumor. So more than 5 centimeter size, deep seated tumor, high grade tumors are indications for radiotherapy and chemotherapy. These 3 points, if you put it in your head, it sort of works for all scenarios in soft tissue sarcoma. And obviously, anything low, any close and positive margin, that obviously becomes a very high indication for post-operative radiotherapy.
Location also matters, like upper limb, lower limb. So maybe mostly upper limb is good prognostic.
No, for indication for RT, will that vary?
Yeah, there are different nomograms. So most of them include location also, like upper limb, lower limb.
Oh God, are we supposed to know these?
Yeah.
Nomograms? Yeah. Oh God.
No, okay. No, not all, but you have to read like 1, 2. So you can go.
Yeah, I haven't read any nomograms, people, but yeah, we'll go through that also, I guess. Okay. So then we need to know. Now I talked about dissection with RT. I talked about giving adjuvant RT. Now, do we have an option to give radiotherapy upfront? So NCCN says when possible, that is their recommendation. I read it. Their recommendation is that wherever feasible, give pre-operative radiation. So there is again a whole debate of which is better, how is it advantageous, how is it disadvantageous, and all that. So our idea is to know who said what and what did they say. So one of the major RCTs that you have to quote in terms of pre-op versus post-op RT in soft tissue sarcoma is Sullivan et al. I have not read the paper. I will be truthful with you. I am just random places I have got all this information from NCCN, from book and from videos. So in short, I'll just tell you what the benefits are and what the disadvantages are for each.
What is the evidence?
Sullivan et al.
Oh, Sullivan. Mostly MS cases, I think.
Maybe I have not read it.
There is one class by Manoj sir, I think.
Okay.
Manoj Pandey sir from BHU.
Themselves are saying go ahead with the pre-op whenever feasible. So there are multiple points here. Okay, first and foremost, what Sullivan et al. Found was that pre-op and post-op are equivalent. Okay, local control 93%, almost the same with post-op also 92%. Overall survival of 73% versus 67%. All that you have to go through. And importantly, the benefit of giving preoperative radiotherapy comes in the fact that the tumor is sitting there. So radiation acts better because of better radiobiology, because the tumor is vascular and is sitting right over there. You can give a smaller dose, which is about 50 gray for pre-op, and post-op you will have to at least give 60 gray. It is obviously easier to target and plan the radiotherapy. It is a smaller field. What happens after you operate is, obviously they have to cover the entire incision, they have to cover the entire cavity that you have left behind and extra. So the field will be more in terms of post-op party as compared to pre-op party. Then another important thing as a surgeon for us is, when you have a doubt, especially when, say, it's very close to a neurovascular structure or even bone or somewhere, like you are not very sure, will you give a negative margin to the patient? In those situations, the periphery gets sterilized better and this capsule also gets more fibrosed when you give a preoperative radiotherapy. So the chances of you leaving behind a microscopic disease, that is an R+ resection, goes lower down once you give a preoperative radiation. Obviously, they've also seen that the patient has a better functional outcome after giving pre-op RT and then surgery is what they are saying as compared to post-op RT. Why? Because the wound complications and the fibrosis. So the difference between complications in pre-op and post-op are, in pre-op, you will have surgical wound complications, but they are acute complications and they are usually reversible. On the other hand, in post-op RT, the complications that come up like fibrosis and its sequelae are irreversible and they are more deleterious to the function of the patient, especially lymphedema. So in terms of inguinal region and all, if it's covered, it becomes more likely in a post-op RT scenario than pre-op. So this is the difference between pre and post. As I said, the only thing I know is Sullivan et al., but you can go through if there is anything else that you can quote for which, like who said that, okay, pre-op RT can be given and is equivalent. Okay, what else? So chemo, if we come to, as I told you, there is again a debate for the role of chemo in sarcoma. But if someone asks you what are the indications for giving chemo in a soft tissue sarcoma, it is again high grade, more than 5 centimeters, and a deep-seated tumor. Pre-op chemo, that is neoadjuvant chemo, almost most studies against this, and if you read that guidelines, the discussion part, they say that they have not found any benefit as such, but you know how they'll write, right? Like you can give in some situations. So obviously the situations where everything is borderline resectable. So when surgery in any part of the body, if you go through, when surgery is the definitive modality of treatment, it is when you are not able to give a positive result. That is, you are not able to make sure that the resection will be R0, or you are not sure about the functional. Somewhere you want some downstaging is when a pre-op scenario comes up with systemic therapy. That is always the case, and that is the case here also. Trials-wise, if you have to mention, there are 2 trials, SMAC and EORTC trials. SMAC trial showed benefit for chemo, while EORTC trial didn't really show much benefit. This is what I have written here. I will truthfully tell you, I have not read both the trials, but yeah, this is what is mentioned. What are the drugs used? We must know. It is, the regimen's name is AIM, which the 2 drugs used are ifosfamide and adriamycin mainly, and Mesna is given for that hemorrhagic cystitis, the rescue. Dosages, if you want to see.
One flow chart is there in Devita.
Okay.
About this. So it is good. It tells clearly like rhabdomyosarcoma and Ewing's we have to give, then 5 to 10 centimeter myxoid round cell in those or more than 10. NACT.
What to give, you are saying? The drugs?
NACT.
NACT. Okay, fine. Because my whole idea was for my extremity sarcoma to cover some Viva questions. That's about it. So I'm still reading. Then an important thing to know is there is a classification which I came through called British Sarcoma Guidelines, which gives us which are the chemosensitive tumors and which are the chemo-resistant and which are the ones which are moderately. I'll share that in the group. There is just a list. But in general, obviously, we know the Ewing sarcoma is a good chemo-responsive tumor. And the bad ones, that is this embryonal and alveolar rhabdomyosarcoma, are chemosensitive. Then the chemo-resistant ones also you should know is also the alveolar soft part sarcoma, which I mentioned can have brain mets, and extraskeletal myxoid chondrosarcoma. Anyway, this table you have to go through and somehow remember and mention. So that I'll share. Then we come to the concept of Yeah, metastatic tumor. So this was all for local, right? Local control में ये सब आया था. Now metastatic tumors. So there is again an idea about lung mets. The lung mets that can present synchronous, lung mets can present metachronous. So how do we deal with them? The lung mets, if resectable lung mets present to a patient with soft tissue sarcoma, and you can offer surgery, you can go ahead and do it. Now the question comes, when do we know if this patient is going to benefit from this? Is this a patient with a bad biology? So they say that if the patient presents with synchronous lung mets, it is better that you do the local regional control, sure, but after 3 months do another CT and see if these lesions are progressing or any new lesions are coming up. If then, there's no point in offering the surgery, right? So the tumor biology can be detected like that is what they say. If stable, you can give a option for metastatic tumor. Another thing is if it comes metachronous, like later. If it does present within 1 year, they say it is pretty bad prognosis, so you should really be on the fence about offering surgery. But if it is after 3 years, it is best results. The margin for lung met, they say, is only 1 cell margin is sufficient. Now I have mentioned here, meaning no tumor on wing. Then open or VATS, I don't know, I have scribbled something, but I'm not able to understand much. We will go through that. Then there are some questions. I think this is again probably theoretical.
The margin for
isolated
primary,
limb perfusion.
The margin for primary, what margin do we take for primary?
So grossly they say 2 centimeters minimum, grossly when we are resecting, or this fascia. The whole concept now is about barriers. So if you are very close to any of these structures, that is a fascia like sacral fascia, periosteum or something, take it along with it. So that gives you this 2 centimeter, 3 centimeter wala margin. So fascia intact is what they say, but otherwise if it is sitting somewhere else, like a location elsewhere, minimum 2 centimeter gross margin.
That's gross or pathological? What is the
pathological is 1 centimeter.
Okay.
Actually, now the concept is slowly coming to no tumor on ink also for sarcoma is what that one. There was one sarcoma, what is that symposium we had attended in Hyderabad only. उसमें ऐसा सब बताया था, but I don't think you can say that in exam. It's always
with RT, na?
With RT. Wide excision is always with RT. Yeah? There is nothing doing without RT unless less than 5 centimeter, low grade, and not deep seated. There you can have a tumor board discussion and then decide not to give RT based on the say functional deficit or something that might come up for the patient if you give the RT in that location. But otherwise, it's always a combo. There is no doubt about that. Then this isolated limb perfusion, infusion, and regional hyperthermia. These are some topics which I have not read too much about, but has come up in discussions. I am not very confident in discussing it. I just written some points here. Regional hypothermia with systemic chemo is still being studied only. There is only one RCT, but it has shown some favorable results. I'm not sure, again, indications and all that. What can you write in an exam? I'm not sure, but we have to read up on this. Isolated limb perfusion is something my boss keeps asking. I have still not read it, but I just know the drugs are melphalan and TNF alpha, which is mentioned, I think, in NCCN only. That's why I've written it here. Okay. Anything else? Please read up. Whatever I wrote, I thought I'll discuss today. Yeah. Anatomy, bahut sara, sub muscles pata hona chahiye, it seems. Insertion to everything. They don't care that you're not anatomy specialist, but you should know everything. All the nerves, all the muscles, all the tests for testing each of those muscle groups. Yeah. ये सब पूछ के ऐसा. हाँ, then brachy. Oh my God. Yes, we cannot not discuss about brachy. So brachytherapy, maybe when I asked my radiation oncologist, which is so brachytherapy is, what do you say, almost standard of care now. We cannot not mention it. So after wide excision, if you are expecting to give a adjuvant RT and you have a setup for brachytherapy, you might as well put brachy catheters is the deal now. At the time of the surgery. That is after you do the wide excision, at the same time put the catheters and keep. Obviously, you'll wait for your final histopathology, or if you're already sure that you have some close margin or something, you can go ahead and start your brachy in the interim. So the radiation oncologist here told me Pistos et al. It was the paper that they all used to quote as the evidence for it. It improved local control in high-grade tumors, but not distant metastasis or disease-specific survival. And fine. Dosages, please go through. That is dosage. Sorry?
No, with invent of IMRT, brachy is not used, right?
I don't know. Our institution, they are very much pushing for brachy now. We have brachy here.
Brachy is in trend, then intra-RT is also in trend.
Yeah. Oh, IORT somebody has bought somewhere and all is being discussed. I don't know the extent to which we have to mention all this anywhere. Questions can come. Theoretically, we should know what intraoperative RT is. Theory question, bahut likelihood hai ye sab. Like this isolated limb perfusion, even though it is not found to be useful, I think comes up in theory. That's what boss was saying. I don't know. I have not read it. Okay. Anything else anyone wants to add?
Anybody wants to study RCC, I can teach if anybody is up for it.
आज के लिए तो ज़्यादा नहीं हो जाएगा.
Later.
Later on, please. Later on.
Sunday. Next Sunday I might not be there.